Hello, future doctors. How are you all? Welcome back to MedSteps YouTube channel. I am Dr. Anand Jana, and today we are beginning one of the most important topics in general surgery series and emergency medicine. So that is abdominal trauma. So this abdominal trauma is very big topic. So I divided into two different parts, part 1 and part 2. So now in this video we are discussing about part 1 abdominal trauma in general surgery series. So imagine a patient is brought to the emergency department after a high speed road traffic accident. The patient is pale, sweating, confused, and complaining of abdominal pain. Within minutes, you must decide whether the patient needs immediate surgery, urgent imaging, and blood transfusion or intensive care. If you are taking any wrong decision, can cost your life. So that is why every medical student have to know must master in abdominal trauma. So this abdominal trauma is one of the leading causes of preventable death worldwide, especially among young adults. Many patients may initially appear stable but can rapidly deteriorate due to internal bleeding from injuries to vital organs such as the spleen, liver, bowel, pancreas, or major blood vessels. In this comprehensive general surgery series masterclass, we will learn about abdominal trauma from basic to advanced level. So we will understand the surgical anatomy, mechanism of injury, pathophysiology, classification, and advanced traumatic life support principles and fast focused assessment, sonographic assessment, and ultrasound and CT interpretation, and how surgeons make life-saving decisions in the emergency room. By the end of this series, you will be able to approach any trauma patient systematically, recognize life-threatening injuries, early interpret trauma investigations confidently, and understand the principles that guide modern trauma surgery. Remember, one important trauma principle: treat the patient, not the scan. Treat physiology before anatomy. So these principles save lives every day in trauma center around the world. So grab your notebook, think like a trauma surgeon, and join me as we begin our general surgery series on abdominal trauma part 1. So let's start without time waste. First, we are going to see here, that is, whenever any patient coming with abdominal trauma. So first of all, mostly we can see motor vehicle accident and everything, this type of things. So actually I want to share one of my experience in accidental emergency department. Actually, when I'm in on call, that time we got one patient because of motor vehicle accident, but the patient is little agitated. So I'm working with one doctor. The doctor said like we have to take rest, so they say gave fluids and everything. But in after some time, I'm done with my clinical rotation and everything, but we didn't did any CT scan for him because he's like stable and he's not showing any symptoms. But after that, I heard when I went hospital in the morning, I heard that the patient have internal bleeding. So after traumatic incident, the patient, we have to check properly. We have to do total assessment and physical examination and another intervention test and everything. So based on that, we can save one life. Okay. So first of all, definition of abdominal trauma. Abdominal trauma is an injury to the abdominal wall, abdominal cavity, or intra-abdominal organs resulting from the external force. So it may involve like solid organs like liver, spleen, and pancreas, and it will involve like hollow visceral organs like stomach, bowel, and blood vessels, and retroperitoneal structures, and diaphragm, and genitourinary organs. So if you are seeing history background, before modern trauma surgery, we have abdominal trauma had mortality rates exceeding like 70%. So right now nowadays major advances we can select trauma system, advanced traumatic life support protocols, and fast ultrasound, damage control surgeries, and massive transfusion protocols. These are the have dramatically improved, and it's improving the survival rate. So in clinical importance, in abdominal trauma is a leading cause of death in young adults. Along with that, we can see young adults and road traffic accidents and assault victims. victims and military injuries. So the major cause of death mostly we can see because of penetrating injuries or blunt injuries or polytrauma. We can see hemorrhagic shock and multi-organ failure because of hypoperfusion and preventable trauma deaths. So why every medical student must know abdominal trauma? Because missed abdominal injuries kill patients. So hemodynamically unstable patients may die within minutes because of internal bleeding. So decision often must be made before complete investigations. So we have some high yield exam points. That is most common injured organ in blunt trauma, that will be like spleen, and second most common injured organ is liver. Okay, so these are the things. Now before going to abdominal trauma, we have to know little surface anatomy. So first of all, we can see here the abdomen divided into 4 different parts. Okay, so this is right upper quadrant, and this one left upper quadrant, and this one right lower quadrant, and this one left lower quadrant. Okay, so like that we can differentiate the abdomen is divided into these 4 quadrants. Then after we can see here, we can see in this picture, we can see total 9 different regions. This is right hypochondrium and epigastrium, left hypochondrium, right lumbar, umbilical and left lumbar, right iliac, hypogastrium and left iliac. Okay, so these are the 9 regions. This is very important because if you know the traumatic that hit or where we have the traumatic and bruising and ecchymosis, based on that you can easily differentiate which organ got damaged. So that's why you have to know these 4 regions, the quadrants, and what are the structures present behind that quadrants. Okay, so next we can see here, that is, we can see some abdominal layers. So for doing surgery, if you want to do incision, so we have to know the layers, the abdominal layers. So first we can see skin. Okay, so first one we can see skin, next subcutaneous tissue, then after we can see here that is carpus fascia, then after muscle, then after we can see campus fascia. Okay, so then after if you are going inside, you can see here this is the abdominal image. You can see here this is the after carpus fascia, after muscle layer, you can see transversalis fascia. This is the transversalis fascia. Then after you can see peritoneum. This is the peritoneum. I'm zooming this picture, and inside you can see abdominal organs. So we have to know this every layers like skin, carpus and campus and linea alba. So these are the step-by-step layers we need, because while doing surgery the doctor maybe can ask in while doing operation in operation theater. Okay, so we have some solid organs, that is liver. It's present in your right upper quadrant. The right upper quadrant we can see the most solid organ is liver and highly vascular and most common cause of massive hemorrhage. Next, in left upper quadrant you can see here that is most commonly injured organ is spleen, and we have some retroperitoneal organs often missed initially, that thing we call pancreas, and hollow organs like stomach, small bowel and colon, and we can see some injuries causes to peritonitis, and it will cause sepsis. Okay, so abdominal trauma, we already discussed about the solid organs and solid organs and hollow visceral and vascular structures and abdominal wall. So before that we have to know some basic anatomical zones. We already discussed in this thing. So retroperitoneal structures, these are the things very important. What it means, we have total 2 different types of organ structures based on intraperitoneal and retroperitoneal. So the abdominal viscera are classified according to their relationship to the peritoneum. One is intraperitoneal organs. It may suspended by a mesentery and are almost completely enclosed to visceral peritoneum, and they are very mobile structures. Next we can see retroperitoneal structures. These are the things we are seeing now. It's like partially covered on one side with parietal peritoneum. Okay, and these are immobile and fixed. So because of that high impact hit or traumatic incident, it will cause injury. Okay, so many retroperitoneal organs originally suspended by a mesentery and become secondary to retroperitoneal organs. Okay, so first of all, the retroperitoneal organs, we have one mnemonic. That mnemonic we call sad pucker. Sad pucker means you can see suprarenals. S means suprarenal, A means aorta, D means duodenum, like second and fourth part of duodenum. You can see here. Next you can see like pancreas, ureters, colon, like ascending descending colon, and kidneys, and esophagus and rectum. So these are the main retroperitoneal structures. In secondary retroperitoneal, you can see what are the things I told now. Everything will comes in secondary retroperitoneal structures. Okay, so here this is the main fusion fascia we can see in secondary retroperitoneal structures, because it will cover by a mesentery and it becomes retroperitoneal structures. Okay, so here we can see major intraperitoneal organs, and these are major primary retroperitoneal organs, and these are the secondary retroperitoneal organs. I already mentioned these things before. Okay, so mostly intraperitoneal organ, retroperitoneal organ, and pelvic injuries is very important in abdominal trauma. Okay, so we have some dangerous zones, that is we call right upper quadrant will be like whenever patient getting right upper quadrant injury, we have to suspect right upper quadrant, we have to suspect patient have liver injury. If left upper quadrant, we have to suspect patient have splenic injury. If patient have flank regions, this flank regions, if patient got injury, we have to think renal injury. Lower chest trauma. So if patient have lower chest trauma, then we have to suspect the injury may be in liver, spleen and diaphragm. Okay, so these are the things. So now normal physiology functions. The liver main function will be like it will help to clotting factor. It will help to in mechanisms like clotting factors, and it will do metabolism and detoxification. This is the main physiological function of liver. Next we can see some spleen. The spleen main function will be like immune function and blood filtration. Okay, so next we can see small bowel will help to do nutritional absorption, and colon main function will be like water absorption. The physiological consequences of trauma can cause injury. Because of injury, the patient can get hemorrhage, and patient will get to hypoperfusion like hypovolemia, and patient will get shock. And because of organ hypoperfusion, the organ cells will become death and multi-organ failure we can see. So now causes of abdominal, the etiology of abdominal trauma, if you are seeing, means total we have three different types of abdominal trauma we have. One is blunt trauma, penetrating trauma, and another one iatrogenic trauma. So first of all, you can see blunt trauma. This BAT, blunt trauma, it's like most common worldwide trauma. Examples we can see in like most common, like 80% of motor vehicle accident, falls and assaults. Energy is transferred without penetration. So that thing we call blunt trauma. So mostly where we can see with road traffic accidents, falls, crush injuries and assault. You can see here this picture, the patient got blunt trauma, this total. Okay. So next you can see here, that is penetrating trauma. The penetrating trauma, it's include like gunshot wounds, stab wounds and impalement. So the patient getting direct penetration of abdominal wall with damage to the internal organs. For example, like stab wounds, gunshot wounds and impalement injuries. So next we can see that is iatrogenic trauma. That is examples like laparoscopic injury and endoscopic perforation. So these are the things will comes in iatrogenic trauma. So next we can see some risk factors, that is motor vehicle accident, that is high speed collisions, alcohol intoxication and no seat belt and violence. Okay, so next we can see here, that is Some commonly affected structures, that is solid organs will becomes like liver, spleen, renal and pancreas. So these are the solid organs. Next we can see hollow visceral organs like stomach and small bowel and large bowel, ascending and descending colon and urinary bladder. Next we can see vascular. The vascular we can see like aorta, in inferior vena cava and mesenteric vessels. And other structures we can see like diaphragm and abdominal wall. So next we can see pathogenesis, or we can tell that thing like mechanism of injury. So first we are going to discuss about blunt trauma. Blunt trauma you can see here, that is sudden deceleration, means motor vehicle accident. So we can see that shear forces tear mesenteric vessels. So for example, you got some external force. Because of that external force you got compression, then after the organs getting crushing and the patient, the organ getting laceration, then after the, because of that laceration the patient will get bleeding, then after shock. So these are the things. So here in blunt trauma we can see sudden deceleration, motor vehicle accident, because of that thing shear tear mesenteric vessels. So these are the mesenteric vessels can get injury. Second one we can see compression, means because of seat belt. So this type of seat belt sign you can see. So these are the because of seat belt compression the patient will get a crash injury, because of bowel will get damage. So next we can see burst injury from increased intra-abdominal pressure. So the mesentery will get injury. This type of structures you can see in while doing surgery. So next we can see that is penetrating trauma. As I told you before, penetrating trauma means it's related to some sharp object or impalement or gunshot. So low velocity knives, it can cause localized damage. High velocity bullets can damage cavitation, shockwave effect and widespread injury. For example, knife and bullet. What will happen whenever the patient got stabbed knife, like stab wound or bullet, then the patient, we can, in that patient we can see tissue disruption and vascular injury, and the patient will get contamination and it will cause peritonitis, then after it will cause sepsis. Okay, then after we can see some cellular events like trauma will cause tissue injury, then after inflammatory mediators will release, then after the capillary will leak, the patient will get edema, then after SIRS like systemic inflammatory response, then after MORS means multiple organ can fail, the organ can failure. Okay, the organ can fail. Okay, so these are the things. Now pathology. In pathology we can divide the classification based on that mechanism we already discussed about blunt and penetrating trauma. By organ we can differentiate like a solid organ injury, hollow viscous injury or vascular injury, or retroperitoneal injury. Means retroperitoneal injury means what are the structures it's coming in retroperitoneum. We have to like sad pucker, as we discussed about that mnemonic. Okay, so that structures of injury means we have to mention retroperitoneal injury. So whenever patient getting any solid organ injury, we can find like the patient can get hematoma, laceration, active bleeding and fragmentation. So these are the solid organ injury. We can differentiate based on this thing, we can do grading. Second one we can say like hollow viscous injury. In hollow viscous injury the most findings will be like perforation, leakage and fecal contamination. Okay, so these are the things. Next we can see here that is clinical features. In clinical features we can see some symptoms. Most common symptom is abdominal pain. So this next we can see abdominal distension. So this abdominal distension suggests hemoperitoneum and perforation. Next we can see in some patients like vomiting. If you patient getting vomiting, that possibly bowel injury. In some patients you can see some like dizziness. If patient getting dizziness, you have to suggest the patient have shock. Okay, then after you can see some guarding. Guarding means whenever you are palpating, the total abdomen that muscle, the abdomen layer will become like stiff and rigidity. So that thing we call abdominal like guarding. If patient have guarding, it indicates peritonitis. Okay, so we can see some signs also. But before that, the guarding, it's because of pain, muscle will contract. Next, we can see rigidity. Next, hypovolemic shock and absent bowel sounds. And we can see bruising like Colin's and Turner's sign. So these are the signs. So we can see some signs, that is the Cullen sign and the Gray Turner sign, and tachycardia, earlier sign of the blood loss, and hypotension patient can get in late signs if patient have bleeding. If patient will get abdominal tenderness if we are suggesting like we have to suggest organ injury. Okay, then after rigidity indicates intra-abdominal pathology. So some classical trauma presentations we have, that is splenic injury means the patient will get left upper quadrant pain. Because of that left upper quadrant pain, we have one special sign, that is Keher sign. This Keher sign, the patient will get pain in left shoulder pain. So because of that left shoulder pain, you can suspect the patient have splenic injury. Next one, we can say like liver injury, right upper the patient will get right upper quadrant pain. Along with that, patient will be in shock. Next, we can see some hollow viscous injury, that is diffuse pain. It will cause peritonitis. Next, we have another sign, that is balances sign. This balances sign, we can see dullness and percussion in left upper quadrant. So if patient getting any pain in left upper quadrant, you have to suspect patient have splenic injury. So next, we can see seat belt sign. The seat belt sign means this one. I'm marking here. This seat belt sign, if patient getting means, you have to suspect some chance of fracture or some bowel injury. So before going to investigation, if any patient coming to emergency department, first we have to do proper assessment. So first we have to do history taking. So if you're doing any history taking on patient, this is very important. That's why I'm discussing this thing. Actually, I forget to mention this thing in notes. So history taking. In history taking, we can say like we have to ask main key questions. That is, first of all, the mechanism of that accident, how that thing happened, and that road traffic accident or fall or stab wound. So you have to know the mechanism of accident, mechanism of injury. So the time since injury. This is very important for finding out of hemorrhage and peritonitis. Next, we have to know the symptoms like pain, vomiting, syncope, and hematuria. And past medical history means it's very important because the patient taking any had any previous surgeries. If patient taking any anticoagulants, this is very important because without knowing we can't do any surgery, because if patient using aspirin anything, the patient, while if you're doing surgery means the patient will get too much bleeding and the patient hemorrhage and patient will die in operation theater. So that's why this is history is very important if patient coming in accidental emergency department. So in Viva, if you are in general surgery department, if you are doing any ASCII, that time the doctor can ask most common organ injury in blunt abdominal trauma means we have to tell the patient like spleen. Spleen is the most common organ injured in blunt abdominal trauma. Next, gold standard investigation in stable abdominal patient trauma patient means contrast enhanced CT. Okay, CECT patient have to do. Next one, we have to do primary survey. In primary survey, the most next we have to do physical examination. After taking that proper assessment, we have to go with physical examination. In physical examination, we have to do primary survey. Next, what? Physical examination. So primary survey you have to follow advanced traumatic life support primary survey, that is airway, breathing, circulation, disability and exposure. After the primary survey, you have to go with secondary survey, that is complete head to toe examination. So in inspection, what we have to look? So first one, seat belt marks. Our patient have any bruising? Our patient have any penetrating wounds? Or evisceration? Our patient have any palpation? While doing palpation, we have to assess patient have any tenderness, guarding and rigidity. If patient, while doing percussion, if patient have any dullness, we have to suspect patient have hemoperitoneum. While auscultation, absent bowel sounds will lead us to peritonitis. If patient have peritonitis, we can see absent bowel sounds. In special signs, I already told before, that is Keher sign. This is the Keher sign. You have to suspect splenic rupture. Cullen sign, periumbilical bruising. Gray Turner sign, that is flank bruising. we have to suggest retroperitoneal bleeding if you are seeing this type of signs. Okay, so next the doctor can ask you some differential, give me some differential diagnosis in abdominal trauma. So if patient getting left upper quadrant pain with shock, we have to suspect patient have splenic injury, so you can give differential diagnosis splenic injury. If patient getting right upper quadrant pain, we can give like liver injury. If patient telling if you are suspecting like peritonitis signs and like guarding, rigidity, patient getting tenderness, okay, then we have to suspect hollow viscous injury. If patient getting back pain after traumatic incident, we have to suspect pancreatic injury. If patient getting like blood in urine like hematuria, you have to suspect renal injury. If patient getting delayed shock, then you have to suspect mesenteric injury. If like flank ecchymosis, if you are seeing, means retroperitoneal hematoma. So if the doctor is asking, just tell me the 5 differential diagnosis of abdominal trauma, we have to tell splenic injury, liver injury, hollow viscous injury, pancreatic injury, and renal injury, mesenteric injury, and retroperitoneal hematoma. So next we can see here, that is investigation. In investigation, the first in bedside we can do FAST. What it means? FAST means focused assessment sonography in trauma. So this is the main thing, will detect free fluid and hemoperitoneum in most important bedside test. So it will detect free intraperitoneal fluids. So what are the things it will do? First one, you can see 4 views in FAST scan imaging interpretation. In right upper quadrant, you can see Morrison pouch. So this is the Morrison pouch. Where you can see this thing? In right upper quadrant. So next we can see left upper quadrant. In left upper quadrant, if patient have any splenorenal recess. So if patient have any hemothorax and anything, you can suspect, you can see in left upper quadrant. Next you can see pelvis. In pelvis, the pouch of Douglas fluid. If any fluid in pouch of Douglas, we have to suspect the pelvic injury, pelvis injury. Then after you can see pericardium. In pericardium, where we are saying the cardiac tamponade and this type of things. The cardiac tamponade means the patient will get hypotension and JVP will extend and muffled sound. So these are things if you are saying, means you have to suspect the patient have cardiac tamponade. If positive FAST scan means we have to do black free fluid, we can see in ultrasound. Okay, black free fluid you can see in ultrasound. If you are getting that type of black free fluid, we have to suspect patient have internal bleeding. Okay, so these are the things. Next we have another scan, that is E FAST scan. E means extended focused assessment sonographic in trauma. So these 4 views you are seeing, right? Like right upper quadrant Morrison pouch, and left upper quadrant like a splenorenal recess. Okay, and if you're saying in pelvis and pericardium, along with that you have to, if you are doing extended, you have to go with lungs, and you have to rule out pleural pathological conditions, pleural evolution. Okay, so next you can go with CT scan. It's okay. If FAST means best for unstable patients for investigation, CT scan means it's best for stable patients. CECT abdomen is gold standard for hemodynamically stable patient and solid organ injury for grading. Next, MRI is rarely used acutely. Okay, so these are the things. Next we can see here diagnostic peritoneal lavage. We can do the thing when we are discussing about management, that time we will discuss about this diagnostic peritoneal lavage. Okay, so here you can see laboratory tests. Some labs we have to do like CBC and hemoglobin and bleeding, and we can go with ABG and lactate for checking perfusion, and coagulation profile is very important, and cross match blood. Okay, so these are things we have to do. So next we can see here, that is we have some classification, that is trauma classification, that is blunt trauma and penetrating trauma, and we have AAST organ injury scale, that is it's using for liver injury and spleen injury and kidney injury. Based on grades, we are going to do management. So in higher grade we have to do the patient has severe injury. So these are the things, the management and everything we will cover in our part 2 abdominal trauma. Okay, so I want to explain this everything because before knowing that grades and everything, the basic concept we have to know. So that's why before we discuss that injuries of liver and the spleen and bowel and pancreas, let's first we have to understand this abdominal trauma. That's why I explained this basic things of abdominal trauma part 1. Okay, so next we are going to discuss about the management, liver, spleen and holoviscous injury means how to manage and everything we will discuss in our next part 2 abdominal trauma. So if you have any doubts you can ask me in comment section. If this video is helpful for you, like, share and subscribe. If you have any concerns or any doubts, you can do comments or you can let me in Telegram group. So I will try to give reply, or we will discuss another topics in next upcoming videos. Okay, so I'm signing off. We will meet in our next video. Till